Management Professional certificate in 2023, and the Medi-Clinic Management Development Program in 2022, and the Fundamental Skill for Nursing Manager certificate in 2021. I have also completed courses in performance management in 2019, certified professional in healthcare quality in 2018, and certified ISO lead implementer in 2017. I have accumulated extensive experience in various roles within the healthcare sector. Currently, I am the emergency unit manager at Medi-Clinic Willcare Hospital. Prior to this, I worked as a clinical quality specialist in Dubai Health Authority. Also, I work as emergency unit manager in Prime Hospital, where I manage the emergency services. And I worked as a staff nurse in emergency department at Siha Abu Dhabi. Earlier in my career, I worked in Ministry of Health Hospital in Jordan as a staff nurse in emergency department. So this experience and the qualification have provided me with a robust foundation in healthcare management, quality assurance, and healthcare practices. So the abstract of my research, healthcare delivery is important part for economic development, and effective healthcare system is important for national development, for providing high quality care and patients' outcome. Reimbursement in healthcare is the payment from insurance company by the healthcare provider, such as hospital, for providing medical services. While fee-for-service is the traditional model where healthcare providers are paid for each service, test, or procedure they perform. And the DRG is the payment system used in healthcare where hospitals are paid a fixed amount for treating patients based on their diagnosis, rather than the service provided. So the research focus and the objective was to explore the stakeholder perception of healthcare quality during the transition from the fee-for-service model to diagnosis-related group model in Dubai Hospital. The focus on understanding the effect of this transition on key quality dimension and stakeholder perception. So to investigate this, a multi-phase qualitative study was conducted, which included a literature review and a structured interview with senior management and case managers across different private hospitals in Dubai. Thematic analysis was employed to identify and interpret significant pattern and insight from the data collected. So the research found that the DRG model is generally perceived as a positive in terms of improving healthcare quality and standardization. It has been associated with better surgical outcome, reduce the length of stay, increase patient satisfaction, and lower the readmission rate. However, there is a concern about the potential compromise in care quality due to the pressure of fixed budget and cost effectiveness leadership. Based on the finding, I recommend the establishment of Dubai DRG system that incorporate local healthcare need and setting. Additionally, future research should include quantitative studies such as longitudinal research to objectively evaluate the long-term impact of DRG model on healthcare quality and outcome. Also, future research should consider diverse stakeholder perception to gain more insight. The statement of the problem: healthcare delivery has essential role in making a country strong and healthy. So good healthcare system not only help keep people healthy, but also reduce the financial strain on the government. How healthcare is paid for affect the care delivery and the quality received. So it's important to check if the payment method used in healthcare are efficient. The two common payment model is the fee-for-service and the DRG. Before or in the past, fee-for-service had some issue like overutilization, high cost, and not enough focus on good quality care. So to tackle this problem, Dubai Health Authority decided to move to DRG model in September 2022. With this change aim to make healthcare more cost effectiveness, accountable, transparent, and deliver high quality care. So the DRG model is expected to encourage cost effectiveness, and it's to improve the healthcare services, and the transition from fee-for-service to DRG in hospital present a significant challenge as its impact to healthcare remain inadequately understood. This makes it hard to figure out if using the DRG payment model will make healthcare better in Dubai hospital or not. So in the study, I aim to address the research question for the transition from fee-for-service to diagnosis-related group model in Dubai hospital and tackle the research problem and the objective. So the first question was, what are the stakeholder perception of healthcare during the transition from fee-for-service to diagnosis-related group in Dubai hospital? While the second question was, how do senior management perceive the transition to diagnosis-related group in Dubai hospital? And finally, the third question was, what are the experience and perspective of case manager regarding the transition to diagnosis-related group in Dubai hospital? So the literature review, as per the published research, there are two major types, as we have mentioned before, the fee-for-service and the DRG. The fee-for-service model is not practical because they focus on charging every service they offer. This includes things like the test, the doctor visit, the consultation, the X-ray. So whatever you will do for the patient, they will charge it against the patient. But using this model was expensive because hospital charge for each service without giving enough attention to delivering high quality service. The fee-for-service model caused various problems with one common issue, which is the overutilization or the potential of overutilization. So while the DRG model is expected to make healthcare payment better, it should help control cost and ensure good service quality because healthcare provider won't receive separate payment for each service. It's worth mentioning that the transition to diagnosis payment model can significantly impact the healthcare delivery in various ways. On the positive side, DRG system often led to improved efficiency and resource allocation, enhanced cost effectiveness, and more transparency and accountability. For example, in England, there have been a reduction in hospital stay and resource use, while in Germany, the same DRG system demonstrates efficient and transparent cost accounting. While in China, it has shown positive effect on cost containment, but have also led to negative outcome reflect in resource use and patient outcome. Meanwhile, in Switzerland, has experienced mixed results, mainly concerning ICU admission policy, length of stay, and mortality rate. So, however, it is important to address the challenges and the potential negative effect associated with DRG system, such as the potential reduction in care quality, negative impact on patient outcome, like readmission rate, and the risk that decreased length of stay might lead to adverse events. In 2020, as we mentioned, the Dubai Health Authority introduced the diagnosis-related group for health insurance in a private hospital. The goal was to enhance the transparency and accountability and encourage cost-effective, high-quality services. So hence our research aimed to explore the stakeholder perception of the healthcare quality during the transition from fee-for-service to DRG in Dubai. So the gap in the research, the existing literature on the DRG payment system discloses mixed results, while some studies emphasize the positive effect on quality, other report mixed or even negative impact. The significance gap is the main focus on financial aspects rather than patient outcome. Also, there is a lack of comprehensive research or study on the impact of DRG in Dubai hospital. So to address this, more study needed to explore the effect of the DRG implementation on overall healthcare quality. This research gap highlights the need for further investigation to better understand how the DRG system influence various dimensions of healthcare quality in Dubai. So the conceptual model in exploring stakeholder perception of healthcare quality during the transition from fee-for-service to DRG in Dubai hospital. efficiency, the DRG model has improved the operational process and resource optimization, contributing to more efficient use of the staff and the equipment. Finally, concerning equity, the DRG model has fostered the greater fairness in healthcare delivery by reducing inequalities and standardizing treatment protocol, thus promoting a more equitable healthcare environment. So here we have seen the data for the perception of case manager on healthcare equality during the transition. So regarding the safety, the DRG model has led to enhanced patient safety through standardized protocol and in a reduction in unnecessary procedure. However, there is a concern about the potential risk of premature discharges impacting patient safety. While the effectiveness, we have seen improved patient care effectiveness and enhanced treatment protocol with increase in efficiency and transparency, and optimal resource use is also recognized. For patient-centered, there is a strong focus on patient-centered care, resulting in high patient satisfaction, emphasized on patient-focused model. However, maintaining personalized care has become more challenging due to the efficiency-driven approach. In terms of efficiency, case managers have seen significant improvement in care coordination and case management efficiency, as well as better resource utilization. The workflow improvement related of the admission to discharge process also noted, and there is a room for improvement in post-discharge care coordination. Finally, with respect to
3 minutes, Ahmed, you have 3 minutes. Wrap it up.
Okay. So only, like regarding the equity, it's improved the equity in healthcare delivery through standardized practice. So the discussion of our research question. So to address our research question, I examined the perspective of key stakeholder, the case manager and the senior hospital management. So research question was, what are the stakeholder perception of the DRG model impact on healthcare equality? So that the advantages, the DRG model enhance efficiency and standardization in care delivery, reduce variability in patient care, improve predictability of cost and the treatment protocol, with aligned with the global standard for cost control and the quality improvement. While the disadvantages, there is a potential compromise in care quality due to the stress on cost control. Also, some challenges has been identified, including significant organizational changes are needed, including update on IT, billing process, and staff training. And the impact on healthcare quality, significant organization changes are needed, included, like the update to IT, billing process, and staff training. While it has positive impact through improved predictability and standardization of the care, and there is a potential risk of decreasing equality due to cost-cutting measures. Ongoing evaluation is important to maintain high quality standard. The research question 2, how do senior management perceive this transition? The DRG model promote cost-effective and high-quality care, improve predictability and standardization, and align with the strategic goal of resource optimization and operational efficiency. The disadvantages, there may be a negative impact on patient safety and care outcome. And one of the challenges that managing organizational change carefully, providing comprehensive staff training, ensure high care standard among financial pressure are key challenge. Finally, the model positively impact care quality through improved efficiency and standardization. However, concern persists about maintaining high quality and safety standard among cost pressure. What are the experience and perspective of case manager? The DRG model encourages systematic and organized patient care, provide standardized treatment protocol. One of the disadvantages, there may be additional workload and stress due to the new responsibility and potential conflict between standardization and individualization of care. The challenges, which is adjusting day-to-day responsibility to the new model, ensuring that cost control does not compromise the individualized care. And the impact on healthcare equality, the model has positive impact through better coordination and outcome. So the recommendation, so based on the research finding that demonstrate how DRG model enhance various dimensions of healthcare equality, such as length of stay, readmission rate, and patient satisfaction, while also addressing concern about managing complex cases and balancing efficiency with equality due to the cost-cutting measures. I propose the introduction of the Dubai DRG system. This model aims to improve the existing DRG framework and address these challenges effectively. Dubai, as a unique city with desire to position itself as a global health hub and a leading destination for medical tourism, they must prioritize delivering high-quality services while managing cost effectively. So the input for that one, for the proposed model, is the stakeholder collaboration and support. We need just to do the data collection management. We need just to have a performance indicator and evaluation. We need to have, like a KPI performance framework, and we need to study the stakeholder perception and the DRG classification and the payment adjustment. So Dubai stand for Dubai stand for data-driven decision making, while U stand for unified patient care, and the P stand for benchmarking and best practices, and the A stand for accountability and improvement, and finally the I stand for incentive and improvement. Each step has got actions and desired outcome, and the outcome or the expected outcome, it has to be to improve the healthcare equality. And we will be having performance report, incentive distribution, and policy adjustment. So the project outcome will be basically based on the effectiveness, efficiency, equity, patient-centered care, and safety, and improve the healthcare quality dimension. The impact on the community, there will be an informed decision-making where, customer can take an informed decision regarding their health when they select a healthcare provider. And there will be a public trust because of the transparency that the system provided. So the conclusion, the transition has mostly improved the healthcare equality in Dubai Hospital as perceived by the stakeholder and the senior management and the case manager. In the effectiveness, the DRG model promotes standard care protocol leading to evidence-based treatment and best clinical outcome. While in efficiency, the DRG model optimizes resources use and reduce unnecessary cost. The equity, the DRG aim to standardize payment. It may affect care discrepancy, especially for complex cases. And the patient-centered, the model enhance consistency in patient experience and may limit flexibility. In the safety, the DRG reduce variability in care of and adhere to the best practices, and the recommendation to establish, Dubai DRG to enhance the efficiency and the healthcare equality dimension. So the recommendation, we need to conduct a quantitative study to have more objective results, such as longitudinal studies. And the diverse perception, we need just to explore the impact of the DRG from the patient perspective or health authority perspective. Thank you so much. That's all.
Okay, thank you, Ahmed. Thank you very much. It was a very pleasant presentation from a pleasant guy with a pleasant appearance. Now it's the turn of Dr. Asim to cross-examine you, and then it will be our turn. Go ahead, Dr. Asim.
Thank you very much. Good morning. Good morning, everyone, and good morning, Ahmed. Well done. I really enjoyed the presentation. The flow is really good, and of course the effort on presenting it in a really nice way. So well done.
Thank you.
Ahmed, I want to start from the beginning. I would like to know a little bit more about the background of the study. Specifically, why the decision was made to transfer from EFS to DRG?
Doctor, yes. The director of the DHA, Humaid Al-Qatami, he decided just to move to the DRG for...
Before. I mean, try not to use a lot of acronyms, you know, and explain what it is. You know, and not everybody knows.
Yeah,
you know.
okay.
So even EFS, you know.
He's allowed to use two. He is allowed to use two abbreviations, FFS and DRG, because it's the title of the research. Other than that, we will kill him if he does introduce anything else.
No, Doctor, actually, you know, like the C4
reduce as much as possible, reduce the jargon, and so everybody can understand this.
So the fee-for-service was used in Dubai previous to the Dubai diagnosis-related group, and for the aim to improve the healthcare services in Dubai and improve transparency and accountability, and basically based on the recommendation of the global literature review, the DHA, they have decided just to move to the Dubai diagnosis-related group just for the sake of improving the transparency, accountability, and the healthcare services in Dubai. They always looking just to benchmark with the best practices, and always looking just not to be behind, you know, like the other country. Always they want just to be, you know, like one of the, as we said, they need just to map Dubai healthcare and be, you know, like as a global hub for healthcare services.
Okay, but what were the problems with the previous system?
The overutilization, Doctor, because, you know, like they have understand that, you know, fee for service will be a room for overutilization. That's why they said that let us, you know, use a robust system.
What is overutilization? Explain that.
So if you will go to the hospital, Doctor, the healthcare practitioner can do everything. And there is, you know, like, let's say, possibility of unethical behavior or attitude in the healthcare service, where the healthcare provider will be incentivized to make, you know, like more orders and make more tests for the patient. So they need, you know, like a transparent system where they will just pay a fixed amount for each diagnosis, and the healthcare provider must manage the patient within the limit of these amounts.
Okay. Did you have the chance to ask or to interview, to ask you know, users, you know, patients, to get their perception on this, their opinion, the difference the new system made to them?
See, Doctor, we have done, you know, like the stakeholder analysis, and we found the case managers and the senior hospital management have high power and high interest. So we consider them just to give us, you know, like a thorough information regarding the transition. Yes, customers, it has to be, you know, like considered, but, you know, like the interest and power grid has given them, you know, like low score. So we consider only, you know, like the case manager and the hospital management. I highly appreciate, you know, like if, you know, like the future study, they can just include the patients just to have, you know, more insight about, you know, like the transition from the patient perspective.
How would patients would patients feel the difference in between the two systems?
So basically, they will just look for the outcome, readmission to the hospital, the service provided, meeting their expectation. Actually, you know, like one of the important things in the healthcare, how to meet patient expectation. In the fee-for-service, usually people or the healthcare provider be able to meet the patient expectation, because whatever patient will ask, they will do it because they will charge it against the insurance. While in the DRG, they will not do anything, you know, for the patient, even if they have asked, but they have to facilitate a clear communication with the patient just to convince him that this is not required. I will give you, you know, like example, when patient will come to let's say emergency with headache, we used to give him to do like a CT for him, because like we will charge the service against the insurance. While in the DRG, we have to conduct like a focus assessment for the patient and see if the CT really required for that patient or not. So they work on defensive, like medicine, where you do everything to exclude everything for the patient. While in the
cases, what was the best practice in handling that headache or that surgery, and then automated or recorded procedures will be taken according to the previous one. So it is not in the hand of the person who is charging the patient. No, it's what has happened with X patient last year, last 2 months. We did 1, 2, 3 CT scan, MRI, whatever, and then we charge this. This is the concept of DRG and FFS. I feel from the way you discuss issues that you do not stress. You talk generally about DRG. Go deeply. You are the specialist. You tell us what is DRG, how it does control the cost, how the cost is being grid as previous precedences. In the UK law, they do not have a law in the UK. They go only for precedences for DRG in the law. So a judge would come and say, because according to the case took place in 1950, I judge what my previous fellow has judged, and that's it. And this is DRG in a general sense. So please go deeply a little bit, so that when you talk about the quality, the effect on the patient, we know that you have mastered your research. Sorry for this interruption.
Thanks.
Thank you, Doctor.
Okay, I want to ask about the perception from the insurance company's point of view. How it actually,
this is one of
it made to them.
I have considered them in the stakeholder analysis. Actually, they don't have they have medium power, while they have high interest. The authority or the DHA, they have the high power, so they can just implement the rules, and everybody has to follow these rules. I know that from insurance perspective, future research should consider them just to understand and have more insights regarding the transition. Actually, I did not try them because I have just follow exactly, let's say, accessible stakeholder with high power and high interest.
So all in all, can you say that the bill has come down, or
yeah, Doctor, absolutely. You are absolutely right. If the patient will come for the tonsillectomy procedure, they use, as we said, they used to charge everything. So maybe the patient, they will give him antibiotic, which maybe the patient does not require the antibiotic, and they will charge that antibiotic. But with the DRG, the hospital must follow the clinical practice guideline. So the patient, if he does not require the antibiotic, he will not be given antibiotic, because there will be a fixed amount. And if you will just give extra resources, this will consume the DRG fixed budget. So the hospital will not gain, a profit. So this is the idea of the fee for service and the DRG. So the insurance, they're absolutely happy with that. But actually, I don't have objective data just to study and to have, an informed decision regarding these perceptions.
So you don't have information about whether the insurance premium has gone down or it's still at the same level? Because
generally speaking, it's below, because we used to have a retrospective data showing that the earning or the let's say the total revenue is more than what we are gaining now. But with the efficiency, the EBITDA or the net profit has been increased. So this is exactly, we are looking for a system to have efficiency, the maximum outcome with minimum resources.
How does it compare with other experiences? I mean, during your presentation, you spoke about the different countries and the advantages and disadvantages of using the system, the DRG. How, from your findings, does it compare, or how different your findings are in Dubai are from the from other countries?
Doctor, as I have mentioned in my presentation, like there is a mixed result. Either some country they said positive, some they said negative, some they with mix, like either positive and negative. Let's say in England.
I understand that. But
yeah.
How now you've got that experience, you've got the different countries, and we've got the output from those countries after using DRG. Now you've analyzed DRG in Dubai. How does that compare with them?
Are
there similar advantages, similar disadvantages, different advantages?
Doctor, there is consensus with the finding, almost, but not with all the literature that I have found. So let's say that the current system in the DRG in Dubai has improved, like the surgical outcome, the length of stay, the readmission rate. While, like the readmission rate is very critical. Why? Because if you reduce the length of stay, we do expect a balanced measures. As per the IHI, the measures has, we have a process measures, we have outcome measures, and we have balancing measure. So what they expected, if you reduce, like the length of stay, you expect a balanced measures, which is the readmission rate. And this is one of the consideration that despite that we discharge patients, let's say within 2 days, we have to ensure that we have given him a follow-up education, because we are trying to minimize the readmission rate. But overall, there is a consensus, but with some literature, and some literature has got, like negative impact, like let's say the case complexity management, it's, like consensus with the other research in the globe.
Okay, thank you very much. I'm done, Prof.
Okay, Dr. Noha, it's your turn. Thank you, Dr. Asim.
Thank you. And thank you, Ahmed, for this nice presentation. I would like to ask you if you had any expected percentage decrease in the cost for the transformation. Like do you have a specific percentage of decrease in the cost of the service?
No, I don't have objective data because, the data is very sensitive here in Dubai. Nobody discloses these data. But as we, recommend in the research that really we need, like a quantitative study. We need, something to be more objective and to show and to be transparent to the public. So the public will just be having a trust in the healthcare services. But actually, I don't have, an objective data.
So it's not. It's a plan to be applied. It's not applied yet.
No, it's applied already, and they started in 2020.
In some hospitals or all the hospitals?
In all hospitals. In all hospitals.
Okay. In your research, I've noticed that you're only studying the private hospitals.
Yeah.
I don't know about the system, the health system in Dubai or in UAE. Do they have public hospitals?
Yes. In Dubai itself, we have a private and the government, but the private has, the higher percentage is 80-20. The 80% of the healthcare provider are private, while the government sector are 20%. So I have focused on the private as they give, the high share, and we are looking, for a representative sample.
But in your opinion, wouldn't it be easier to apply this transformation in a public hospital where the restriction of profitability and you having to convince the stakeholders of the cost effectiveness for their profits for the business? Wouldn't it be easier to apply it to public hospitals?
I believe yes, because in the public they have the idea of cost effectiveness. Actually, in the Dubai, the the government facility was operated by the Dubai Health Authority, but recently, because of the transparency, they said that we cannot be the operator and the regulator at the same time. So it has been given to, let's say, semi-government facility to operate the government hospital. So now I think they have the focus on the cost effectiveness as the private sector, and this will impact, like the healthcare quality in Dubai.
Yeah, I think you should include that in your dissertation, because it seems unlikely for stakeholders to convince them of the decrease in their profitability. It's really hard to do that with regards to their point of view of it's a business, and they need to get as much profits as possible out of that business, regardless of other targets. But yeah,
exactly, doctor. And this is the idea. They told them that we will pay you, but you have to have a cost effectiveness strategies to offer, high quality service with minimum resources, while you are maintaining the key performance indicator, or some indicator that you have offered high quality service. That's why in the DRG model, let's say that if the patient he develop a hospital acquired infection, the insurance will not pay for the extension. So this is they consider it as a bad performance, and they will just only pay the fixed amount. So now hospital, they have to make sure that they have deliver high quality service while maintaining, the cost of operation. That's why
that's a challenge, yeah.
Yeah, and that's why they are using now currently a generic medication, not, a branded medication for the inpatient, just to, the cost of operation.
Okay. In your opinion, would this a transformation or the new system, diagnosis-based system, will it be applied to other countries in the Middle East, like in Jordan, for example?
Yes, Doctor. I think this is, an efficient system, but it has, the implementation. It has to be very clear from the beginning. There must be some training. People, they have to understand the idea behind the DRG. Do not take it in the negative side. Take it in the positive side, that this will have, an efficient healthcare system. And even it will attract people just to come, because now we have a transparent system. There is, many, let's say, news where, they said, if you will go to this country, they will charge you, maybe 10,000, 20,000, because they use the fee for service. While the DRG, it's very transparent, and it will enhance the healthcare quality and the medical tourism. So I highly recommend that it can be implemented in Jordan as well.
Okay, the last question. Will this bear more work on the physicians who are supposed to do the diagnosis?
Again, Doctora?
Will this add more work to the physicians, the doctors who are supposed to do the diagnosis?
Yeah, I think mentally, yes, because they have to be, they have to use the clinical practice guideline. They have to check patient carefully and do only the required investigation and, let's say, test for the patient. Not like before, do everything to exclude everything. So I think mentally, they should be alert. They should use, the clinical practice guideline just to have, the best outcome.
So the responsibility would be on the doctors now to determine
yes, at the end, the ultimate responsible is the doctor.
Do you think they would accept that?
No, some doctors, that's why, in the doctor, we said that in the stakeholder analysis, they have less interest and maybe they have less power. Because at the end of the day, if there is a medical error, they will be called by the Health Authority just to do the investigation. And why you did not do this one, why you did. And the justification of the DRG will not be, acceptable.
Great. Thank you.
Thank you.
Thank you, Professor Amda.
Okay, thank you. Ahmed, I'll take the other part. I'm not convinced of your study. I do not believe this is for the sake of argumentation. Let us assume that I am in a traditional hospital and I have my doctors trained and honest. and they go for the FF system, what would prevent them from being or getting the best benefit for the patient and for the hospital and for its finance, for its, I would say, profit? This is my first question.
Doctor, as we explained that, fee for service will give, the comfort for the physician to request everything. Sometimes you have doubt on the patient, so you do.
This is not acceptable, because, as Dr. Noha said, if the physicians, the doctors, are directed to have, even in the DRG system, so many wide diagnostics, I would say, services from the hospital, laboratory tests, whatever, X-ray, MRI, this would be the same situation. When you compare it, it is at the end of the day in the hand of the physician who would say what to do, what not to do.
For the fee for service, doctor, nobody will questioning them. So except, like the insurance, sometimes they said, maybe they reject the service and then they have to justify.
Ahmed, answer my question. This is a critical issue for research. It all based on the honesty of the physician. So if it is FFS or DRG, if the physician is directed because of the greed of the management of the hospital, please do as much tests as possible so that we ensure the health of the patient. This would not make any difference between the FFS and DRG. What do you think?
Doctor, I'm not sure if I have understand your question or not, but what I understand that like the doctor behavior and attitude has been changed from the fee for service to DRG. From fee for service, they used to do everything, but now in the DRG, they have to make sure that whatever is done, it has to match with the patient condition.
Okay, what prevents when you say DRG? They have to. And the beginning, doctors, they don't have to do everything in the FF system. If they are honest, they will tell you, don't take MRI, don't take CT.
But we cannot ensure that
CBC, and that's it.
Always there is, maybe, like a strategy to prevent the unethical behavior in the healthcare system. So this is one of the challenges.
Okay, Ahmed, I'm not convinced in this part. Component of DRG. If I want to apply it to a Jordanian private hospital or Egyptian hospital or whatever, what are the components that I want to prepare the ground, the foundation, so that I can apply this? What are the components of DRG?
So the diagnosis, which is the total diagnosis of 996 diagnoses, it has to be identified, and they have to link each diagnosis with certain amount of money. This is the first step, and the stakeholder, they have to sit together and to have.
I think this is my question, Ahmed. This is not my question. I want to apply a complete system, DRG, to a private hospital, a huge one, in another Arab country, other than the United Arab Emirates or whatever. What mechanism, what components of the system I should have in my hand so that I tell them, look, stop FFS. This is my new system. What are the components of this DRG system?
The structure, process, and outcome. So the structure, which is the policy, the identification of the DRG, and the process, the implementation of the DRG.
If I take your statement, this will be DRG. I want to apply DRG. Go out of your frame of work and understand my question. You are now the manager. If we've kidnapped you from your current position and we put you in a new hospital, in a new job, in a private hospital, big 1,000 bed hospital, and we would like to apply the DRG. Give me the steps. Give me 5 steps how to apply the DRG.
First, doctor, before the implementation, we have to see, like the top 10 diagnoses in the hospital, to see, like the current cost and, compare it with the current DRG cost. Then they have to do, like a specific training for the people just to do the billing process. The IT system, it has to be, like change just to adapt with the DRG. Also, we have to consider the billing process, as we have said. After the implementation, we must have, like a continuous monitoring and evaluation for the DRG outcome.
Okay, if I bring a machine and a software, what is the name of the software that you use for DRG? I think that the main issue here is the software, and I'll take it to 3 other levels. But let us take it one by one. What is the software that you use at the moment?
The EHR, the electronic medical record, Doctor, only. The internal system of the hospital, which is, like the EHR. There is no separate system for DRG as a DRG separate. It's only a document. It's only understanding.
You said we have about 1,000 diagnostics in 4 different 1,000 cases, and these would imply to have or would have a relation to the DRG previous history or costing scheme, صح?
Yes, it has to be incorporated.
How do you do this by only having medical records? It does not compute in here. You should have a system. Listen, please do it. You should have a system in which you put the 1,000 different diagnoses, and then you connect them to 1,000 costing, processing, needed tests, needed healthcare. So for every single, the doctor, the physician would come and say, case headache, what we have done before, these are the tests that we need to do, CBC, whatever test, and then this is the cost. What is the name of this software? If you don't have it, I believe, without waiting for your answer, it must be there. Otherwise, there is no system.
No, there is the diagnosis itself. It can be incorporated to electronic medical records only.
No, can be, has nothing to, excuse me, it has to be, it can be this nonsense for me. You are talking about an implemented system in the United, wait, you are talking about an implemented system in the United Arab Emirates. In the United Arab Emirates, I know them, they have the edge of software technology. So if you go to a physician and he would say, okay, this is the symptom, he would shut up after that and everything will be there. The tests, the cost, everything. This is the benefit of DRG. So you want to tell me that they do not have, and this can be done later? No, it has to be there. So I wanted from you, Ahmed, I wanted from you two things. Under the methodology, to add a section about your case study, 2 to 3 pages. Tell us about the hospital you have done, or hospitals you have done your work on, and then about the system that you have using, the IT system with a small system analysis. They call it ERB or database related, how it is connected, and give us one case, complete full case of FFS. We need this. And complete case, the same case under DRG. What will be the difference in how the way, the mechanism, the way you handle it, the way you reach conclusion, the way you bill it. You give the bill to the patient, and you say, okay, for FFS it will cost 20,000 dirhams. For the DRG it would cost 30,000 dirhams. Not 10, because this is the proper way to do it, because one of the benefit is the optimal way of handling the bill. The optimal, it does not mean that you need to have the cost reduced. The optimal means that you have a proper test that would lead to proper treatment. And in the FF situation, it might not be the case, because it is not supported fully by a system. It is supported by the physician opinion or the emergency department opinion, whatever. Okay, this is first, number one. I want to see it in your research. I like your research, but we want to enhance it. The second thing, I would see in 10 years that we don't have to have lots of physicians at hospitals, because if you want to go for DRG, why not to go for AI? So the patient would go through what is your symptoms, 1 to 3. Very minimal effort of the physician, and then the AI or the decision support trees would tell us automatically what to do, and that's it. This will be the end of the story. What do you think of this?
Doctor, yes, very interesting question, but the AI still there is a room for mistake. So we cannot guarantee 100%.
But the concept of DRG is the base for having the control of AI in 10 years time. And I promise you, if we live for the coming 10 years, you'll find that AI based on the DRG, not FFS, on the DRG, because DRG is a situational diagnosis that would depend on the precedences, the previous expertise. So, okay, the final, actually, another one question, two questions.
Doctor, you said the final, huh?
You said disadvantage, and the only, what I can see from your research is that you have a structured interview with the managers. You did not have a questionnaire and that much. Is that right?
Yeah, only interview, Doctor.
Interviews. I could not. I've been through your questionnaire. Actually, your questions to the managers. I could not know how on earth you reached the conclusion that there is a disadvantage of the DRG that you mentioned in here. Can you read the disadvantage in here?
Yeah, potential compromise in care quality due to the cost control, emphasize the risk on reduction in necessary service, potential decrease in quality care provided.
This is not based in any question of your structured interview. Is it your personal opinion?
No, Doctor. In the structured interview, we have asked about the overall perception. What are the key benefits and weaknesses?
The whole idea. You break your research by having this disadvantage. The whole idea, you are telling us that this is much better, the DRG. It will optimize. Please use the word optimize, not reduce. Because if you are after reducing the cost, it's an economical issue. It's a cost, not cost benefit. So let us use the word optimize and define it. So if we want to approve this, it means that we have disagreed on every single result on your research. You said disadvantage. Why on earth do we have disadvantage if you keep talking for the 100 pages before that DRG is much better?
Yeah, Doctor, this is a perception study, and this is only a potential compromise in care quality. It's not, like actual compromise in care quality.
So the conclusion here, don't go for DRG because it has a disadvantage in cost control and in risk reduction, and actually everything is in this small 3 lines.
That's why, Doctor, we have asked for a quantitative study, which will make will conclude a better outcome. So once
you are not proposing a new system. You are evaluating an existing, already in place for the last 3 or 4 years system. So you don't say that we recommend. You are testing what is available, at your hospital, at the place that you are doing. So please reconsider this. Make sure that it is not there. And if it is there, it has to be, you have to change the conclusions of your work. Okay, my final question would come here. Your model. You said that this is your model, the model that you've introduced, صح? Or is something that generic? Okay.
No.
I did not see. I did not see in your research any KPI approach, key performance indicators for your work. Where is it? In which place of your research? Because you put it as a bridge, actually as a barrier before going further to have KPI. And I agree with you. Where is it in your research? How did you get that? Where is it in your question that you've raised?
It's available, Doctor.
Which table? It's not in your conclusions. It's not in your, I would say, analysis. It is not in your literature. So where is it?
Let me, Doctor.
Okay, Dr. Asim, everybody, I'm done.
Okay, thank you very much. I'm okay as well.
Dr. Noha?
Thank you, Doctor.
Okay, Ahmed, thank you very much. Our questions, tough questions, does not mean that you did not do a good job, but it means that we want to enhance your work by having these dimensions. The remarks from Dr. Asim, Dr. Noha, and the hammering from me is to make everything better, inshallah. Okay, we will leave you for a bit. Don't escape, stay around, and we will come back to you. Salam. كيف الأعصاب أحمد؟ كويسة؟ أحمد افتح الميكروفون.
مرحبا دكتور.
كيف أعصابك؟ تمام؟
والله الحمد لله، اللي برضى بعيش.
الحمد لله. ثواني بس أفعل التسجيل مرة ثانية. Okay, we are reconvening again after deliberation session for the Board of Examiners, and we've reached a decision that will be delivered by Dr. Asim, the main examiner. Go ahead, Dr. Asim.
Thank you very much. Bismillah ar-Rahman ar-Rahim. First of all, Ahmed, I want to congratulate you on your presentation, on your defense. I think all of us, we enjoyed both. We enjoyed the presentation and the defense itself. Yes, we had a discussion about your performance, and we have reached a decision. And we are happy to tell you that you have passed.
Thank you so much. Thank you.
Without anything, just passed.
Thank you, Doctor. Thank you.
Well done. Well done. Congratulations.
The dream became now the reality. This is a dream from 2013. Now, alhamdulillah, we achieve it. Thank you so much.
You deserve it.
You deserve it. You deserve it. You deserve it, Ahmed. Mabruk. Congratulations and welcome aboard, Dr. Ahmed.
Thank you, Doctor, and all the best for my colleagues. Thank you.
Inshallah. All right. Shukran, Ahmed. Our next